Good afternoon, everybody. Welcome to Grand Rounds. Today, I have the extreme pleasure of actually introducing co-presenters. We have Kimberly Case, who has been the diabetes nurse practitioner here at MGMC for, I think, 5 years. And also Yamuna Gorantla, who is a board-certified endocrinologist, member of the McFarland Clinic and on the MGMC staff for about the last 4 years. I can personally attest to the fact that they are incredibly competent and have been just incredibly helpful in regards to helping me manage my patients with diabetes. And CME committee is just really appreciative of the fact that they've taken time out today to provide us with a view of diabetes. And the title of their talk is Diabetes, Screening and Monitoring and in Between. And please join me in welcoming Kimberly Case and Yamuna Gorantla.
Hi, thank you. My name is Dr. Gorantla. I'm one of the endocrinologists here. So today, me and Kimberly Case are going to talk a little bit about the diabetes and diabetes technology. Again, there is a lot more to talk, but because of the time, we have limited a lot. If you have any questions, you can ask us at the end. So let's start with the presentation. So this is the outline. So today I'm going to talk about the types of diabetes, diagnostic criteria, type 1, a little bit regarding the Tzield, which is the new medication to delay the onset of type 1, and then who to screen for type 2 diabetes, how to prevent the prevention of type 2 diabetes treatment and monitoring, and then diabetes technology. So first, regarding the types of diabetes, as everyone knows, type 1 or LADA, which is an autoimmune diabetes, and then type 2 related to obesity-mediated insulin resistant, and then gestational during pregnancy, and then diabetes from other causes, which is monogenic diabetes, or also called MODI, and then pancreatic diabetes or drug or chemical-induced diabetes. And then diagnostic criteria, we have 4 diagnostic tests to do to screen for diabetes, and we need at least 2 tests positive if they don't have the hyperglycemic crisis. If they have hyperglycemic crisis, then yes, obviously they will meet probably 2 criteria anyway. So first A1C and then 2-hour glucose, 2-hour OGTT glucose or fasting plasma glucose or random blood glucose. So A1C, we call it as pre-diabetes if it's between 5.7 to 6.4%, diabetes is if it's 6.5 or above. 2-hour OGTT glucose, pre-diabetes will be 140 to 199, and diabetes will be 200 or above. Fasting plasma, 100 to 125 is the pre-diabetes, 126 or above is the diabetes. Random plasma glucose over 200 is the diabetes. Type 1 diabetes. So as we all know, it's an autoimmune disease. Definitely the autoimmune attack against the pancreatic beta cells, causing destruction of the pancreatic cells, causing insulinopenic state. As we all know, it's definitely a genetic risk, but 9 out of 10 people with type 1 do not have a family member with type 1 diabetes. But if they have a family member, there is definitely a 10 to 15% increased risk of developing type 1. There are 3 stages in the type 1 diabetes, stage 1, stage 2, and stage 3. All the 3 stages have positive antibodies, but stage 1 is normoglycemic state, stage 2 is the dysglycemia, which is basically kind of pre-diabetic state, and then stage 3 is the hyperglycemia, which is the full-blown type 1 diabetes, and they're at risk for DKA. And when do we screen for type 1? So obviously, if we are suspecting a young patient with hyperglycemia symptoms, we screen them for type 1 diabetes, mainly autoantibodies, but I also check C-peptide because it helps us guide the treatment. So these are the 5 antibodies that we can check. Most popularly used is the GAT65 antibodies, but we can also check IA2, zinc transporter 8, IAA, and the ICA512 antibodies. And the reason why I check C-peptide is if the C-peptide is normal, that means they're still in the stage 1 and stage 2 of the autoimmune diabetes. If the C-peptide is low, that means they're in the full-blown stage 3 and they definitely need insulin. And if they're in stage 1 or stage 2, we can do the blood glucose monitoring at home, and A1C obviously every 3 months, 6 months, or 12 months. I usually do 3 to 6 months, not the 12 months. This is the Tzield or teplizumab. This is the first FDA-approved medication to delay the onset of type 1 diabetes. So it's a monoclonal antibody indicated to delay the onset of stage 3 type 1 diabetes in adults and pediatric patients over 8 years who are already in the stage 2 diabetes. That means in the dysglycemic stage. It works by binding the CD3 molecules on the T lymphocytes such as the CD4 and CD8 cells, which are involved in the autoimmune destruction of the pancreatic beta cells. This is a picture that shows, so basically this is the Tzield which binds to the CD3 molecule and it deactivates the autoreactive T cells so that they're not destroying the pancreatic beta cells. Treatment for diabetes, only insulin and insulin, either through the multiple daily doses of prandial and basal or through the insulin pump. We prefer using the insulin analogs, that are the synthetic insulins, over the human insulins because of to minimize the hypoglycemia risk. And obviously, use of CGM is recommended in every type 1 patients, and automated insulin delivery should be considered if the biggest thing is the cost. If they can afford, yes, that's the best one. And then obviously emergency glucagon should be prescribed for all type 1 patients. And most importantly, we have to educate patients to match their mealtime insulin based on their carb intake and the correction dose based on their current glycemia, and also look at the glycemic trend if they're sick, and also anticipated physical activity to avoid hyper and hypoglycemia after the meals. And also we have to educate them regarding the timing of taking insulin. We recommend at least taking 10 to 15 minutes before eating a meal. And there's a picture from the ADA 2024 guidelines which shows us what are the different insulin regimens we can use, and also the insulin infusion pumps. And here it tells us which has the most flexibility and the lower risk of hypoglycemia and the cost wise. So obviously the top one, the multiple daily dose injection with long acting, and then rapid acting or ultra rapid acting insulin has the greatest flexibility, low risk of hypoglycemia, but unfortunately it's expensive. And if you look at this, the human insulins, which is the NPH and the regular, has less flexibility, more hypoglycemia, and then it's cheaper. So when they don't have insurance, or when the insulin is very expensive, this is a cheaper option which they can also buy over the counter. And among the insulin pumps, obviously the newer insulin pumps which have automated insulin delivery systems, which is the Medtronic 780G Tandem, Control-IQ, Omnipod 5, of course they have the greatest flexibility, very low risk of hypoglycemia, but unfortunately are expensive. And these are the different insulin preparations we use. This is the prandial insulin, either the regular, that's a human insulin, or the rapid acting and ultra rapid acting insulins. So Lispro ABC is the new insulin, that's the Limjev, Aspart or Novolog. Faster aspect is the Fiasp, and then Glulicin or the Epidra. And basal insulin can be the intermediate acting insulin or the long acting insulins. Detamir is out of the market now. We use Glargine or the Deglutec mostly. And these are some of the pre-mixed insulin combination. Aspart is the Novolog 70-30, which is 70% is the NPH and 30% is the Aspart. That's why it's Aspart or Novolog 70-30. This is the Humalog 50-50, Humalog 75-25. This is the Humulin or Novolin 70-30, so it's NPH and regular insulin, not the Aspart or the Lispro. This one is also available over the counter for the patients to use. So when they don't have insurance, that's another cheaper option. Pre-mixed insulin and GLP-1 agonists, this is for type 2, not for type 1 patients. But yes, we have, let's say we have Medicare patients who are obese and they cannot afford GLP-1 agonists. This is one which is $35. I know Soliqua is $35. I don't know about the Zultofi. I haven't seen any rep for that. So I know Soliqua is again available in the $35 plan for the Medicare patients. So that's a good combination if they're interested in losing weight. Now let's talk about the type 2 diabetes. Who do we screen for type 2 diabetes? Every 3 years, any person over 35 years age, we need to screen them for diabetes every 3 years. Prior GDM without risk factors, we do A1C every 3 years. Annual screening we do for those who have history of prediabetes, those who have prior GDM with risk factors, people with HIV, who have exposure to the high risk meds, pancreatitis. Okay, those who have cystic fibrosis, adults with overweight and one or more of the risk factors like family history of cardiovascular disease, high-risk ethnicity, hypertension, PCOS, hyperlipidemia, physical inactivity, or other conditions with insulin resistance. And the only thing that can prevent the onset of type 1 diabetes, let's say that you have an obese patient or those who have a strong family history of diabetes, we have to talk to them regarding the lifestyle modification with healthy eating habits, and then regular physical activity, total 150 minutes per week of moderate physical activity. And we can also educate them regarding the diabetes prevention program, which has shown that intense lifestyle intervention reduce the risk of developing type 2 diabetes by 58% over the course of 3 years. And this is the only medication, metformin. We have to delay the onset of type 1 diabetes. We can use it in obese patients with BMI 35 plus, impaired fasting glucose with sugars 110 plus, or A1C, pre-diabetes if their A1C is over 6%, and those with history of gestational diabetes and PCOS patients. And these are the different treatment options we have for type 2 diabetes, multiple options, but the highlighted ones are the most commonly used. I have never used these classes except the meglitinates. I have used one patient who have kind of side effects with all the above medications. So, but these are the most commonly used medications, which I'm going to discuss over the next couple of slides. So I'm going to talk the cost, whether they're cheap or expensive, what's their effect on the weight, whether they're high efficacy or intermediate efficacy, how they work, what are the side effects, and benefits. So first, let's talk about the metformin. It's a cheap medication. As we all know, it's a weight-neutral medication. That means it doesn't help you with weight loss or weight gain, but some patients do lose weight even with the metformin. It falls under the high-efficacy drug. That means it can lower down A1C up to 2%, helps with insulin-resistant, contraindicated if the GFR is below 30, has GI side effects, and there is a risk of developing B12 deficiency. I usually monitor B12 level every 5 years when they're on metformin, or as needed if they have any neuropathy symptoms. And then the dual GLP and GIP receptor agonist, it's tirzepatide or Mounjaro, trade name or brand name Mounjaro, has been in the market for less than a year. It's expensive, but it has the most weight loss benefit among all the diabetic medications. It's a very high efficacy, can lower down A1C up to 2.5 or even more. I have seen some patients even 3 to 3.5%. It works by basically stimulating the GLP and the GIP receptor. So glucose-dependent insulin secretion improves insulin sensitivity, inhibit glucagon release, appetite suppression benefit, and also delays the gastric emptying. It's contraindicated if any prior history of pancreatitis or family history of medullary thyroid cancer, and does have GI side effects. And next, let's talk about the GLP-1 receptor agonists, which are in the market for probably like around at least maybe 6 to 10 years. I have not since my residency, so at least 10 years probably. We have an oral drug. This is the only oral medication we have, Rybelsus, and all the others are injectable. These two are the weekly injectables. This is the daily, and this is also a weekly injectable. And these are also expensive, helps with weight loss, high to very high efficacy, 2 to 2.5 A1C lowering benefit. They work similar to the dual agonist, which is glucose-dependent insulin secretion, inhibit glucagon release, appetite suppression, and delayed gastric emptying. Contraindicated, again, the same way if any history of pancreatitis or family history of medullary thyroid cancer. Same GI side effects, but this class has the known cardiac and kidney protective benefits. Not all the medications, only these 3 medications: Ozempic, Trulicity, and Victoza. So if they have any cardiac history, yes, we prefer these 3 GLP-1 agonists. And next couple of slides, I have added some evidence regarding the cardiovascular and the renal benefits with the GLP-1 agonist, which I'm not going to talk, but if you have any questions, I can answer. And next, the SGLT2 inhibitors, which are expensive, helps with weight loss, intermediate to high efficacy, can lower down A1C up to like 1 to 2%, needs renal dose adjustment. I usually try to avoid if the GFR is like below 30 to initiate. If they're already on it, then up to 25 GFR is okay to use. We try to avoid below 30 just to avoid dehydration and further worsening of kidney function. And it works by lowering plasma glucose by blocking the reabsorption of filtered glucose in the kidneys. Side effects, a little bit scary when we talk to the patient regarding the side effects, but because the benefits overweight, these are still the preferred medications. So there is a risk of euglycemic decay, Fournier's gangrene, muscle necrosis, UTI, genital mycotic infections, a risk of dehydration, so that's why we have to carefully monitor the GFR, and possible worsening of bone density. And it does obviously have cardiac, heart failure benefit, and the kidney protective benefits. Among the 4 medications, all medications have heart failure benefit except, and also cardiac and kidney protective benefit. Actually, Farxiga also have the cardiac protective benefit. I forgot to add that. Except this etugliflozin, which just have the heart failure benefit, but not the cardiac or the kidney protective benefit. And this is some literature which showed that. And next class will be the DPP-4 inhibitors. Again, these are expensive, but maybe a little bit cheaper than the GLP-1 agonist and the SGLT2 inhibitors, but they are weight neutral, intermediate efficacy, again, needs renal dose adjustment except the Tregent or linagliptin. And it does increase endogenous GLP-1, thereby increase insulin release, decrease glucagon secretion, contraindicated if any prior history of pancreatitis. There is some side effects of liver toxicity and hospitalization for heart failure, but I haven't seen much, and these are the drugs we have available. I don't usually start them on DPP-4 because they're almost as expensive as the GLP-1, and they're weak intermediate efficacy, and they're weight neutral. So if they're spending that much of money, we prefer the ones which are cardiac protective, which are high efficacy, and which can also help you lose weight. So that's why I don't use much DPP-4 unless I don't have any other options. Okay, then sulfonylureas, these are the three, we are no longer using the first generations because of the risk of hypoglycemia. The three second generation drugs are the glipizide, glyburide, and the glimepiride. This is another cheaper option, but unfortunately causes weight gain, has high efficacy, 1 to 2% lowering, stimulates insulin release through the pancreas, risk of hypoglycemia, so that's why we have to use them carefully in elderly patients, particularly when they have chronic disease, chronic kidney disease. In elderly and those who have chronic kidney disease, stage 3B to 4, I try to avoid glyburide because this is the longer acting drug. Thiazolidinedione, which is pioglitazone or Actos, it's another cheaper option, causes weight gain, intermediate to high efficacy. I haven't seen 1.5, at the most I have seen probably 1% A1C lowering, improves insulin sensitivity, not recommended in chronic kidney disease or liver disease patients due to the risk of fluid retention and increase the risk of heart failure. And there is also a possible worsening of bone density, so try to avoid in osteoporotic patients, and also has a bladder cancer risk. They say that there is a potential cardiac benefit, but probably not a significant improvement, so that's why it's not a big benefit from it. And next, the question is when to add insulin. Per guidelines recommend adding insulin if they have a high A1C, over 10%. But even in this situation, I have controlled with the pill, so it's not necessarily that if the A1C over 10, we don't have to jump onto the insulin if we can get it under control with other options. But yes, per guidelines, if it's over 10%, yes, we have to start them on insulin. Or if the blood sugar is over 300, or definitely if there are signs of catabolism, then yes, we recommend starting insulin. And let's say that if you are unable to control A1C if they're already on multiple oral pills with the GLP-1 or the dual injectable, then yes, we add insulin. Beyond metformin. So whenever we are treating type 2 patients, we have to think beyond metformin and by looking at the risk factors. So if they have cardiac risk factors, then our first recommendation would be to start the GLP-1 agonist and the SGLT2 inhibitors. And not all the GLP-1s, of course, Ozempic, Victoza, or Trulicity. Those are the three medications that has the cardioprotective benefit. So we prefer those three or the SGLT2 inhibitors. If they have heart failure, yes, we prefer the SGLT2 inhibitors. If they have chronic kidney disease, again, SGLT2 inhibitors or the GLP-1 agonist, which has the renal protective benefit, which is again Ozempic, Trulicity, Victoza. And if it's just the glycemic control, then yes, we can do any medications which has high efficacy in lowering the A1C. If it's obese, then yes, we prefer the weight loss medications. So most effective for weight loss, very high efficacy would be the subcutaneous semaglutide, which is the Ozempic, or the tirzepatide, which is Mounjaro. High efficacy will be the Trulicity or the Victoza. Intermediate or the other GLP-1 agonists like the Rybelsus, Byetta, Bydureon, and the SGLT2 inhibitors. And neutral, DPP-4 and metformin are the weight neutral medication. If we want glycemic control, then very high efficacy drugs are the Trulicity, the dulaglutide high dose, subcutaneous semaglutide or Ozempic, tirzepatide or Mounjaro, and obviously insulin or combination oral pills or combination injectables. High efficacy are the other GLP-1 agonists, metformin, SGLT2 inhibitors, sulfonylurea, or pioglitazone. Intermediate efficacy are the DPP-4 inhibitors. Where to start? My goal is, my first preference is the GLP-1 agonist if they're kind of in middle-aged patients, but I prefer the Mounjaro, that's a dual receptor, if they're very young patients and really bad obesity, and can be used in combination with other non-insulin therapy. There are a couple of new options. I mean, this is probably the only new one that's available in the market. FDA approved sotagliflozin. It's a dual SGLT1, SGLT2 inhibitor, which has a full range of heart failure benefits, so both preserved and the reduced ejection fraction, so as the other SGLT2 inhibitors. So it inhibits basically 90% of glucose reabsorption in the kidneys, and in addition, it also inhibits 10% reabsorption in the small intestine. And this is a study, the SOLICIT trial, which has shown that it has decreased 33% reduced cardiovascular event rate, decreased cardiovascular or all-purpose death rate from the heart failure, basically. And this is the drug under clinical trial. So semaglutide semaglutide is the single GLP-1 receptor agonist. Tirzepatide, it's a dual receptor, and there is a next big wave in trials, which is the triple G agonist. It's called retatrutide, which is a GIP, GLP, and the glucagon receptor agonist. So hopefully that has more weight loss and more A1C in addition to the cardiac, and obviously also cardiac protective benefits. But that's in trial, probably won't be in the market for another couple of years. So if they're already on treatment, we have to know whether it's controlled or is the plan working or no. And how do we know that? Based on monitoring of our blood sugars and the A1C. So fasting plasma glucose should be between 80 to 130, and the peak postprandial, that's a 2-hour glucose, should be below 180, and A1C for most non-pregnant patients should be below 7%. I usually aim to get around 6.5%. Again, there are some exceptions, except during pregnancy or women planning to get pregnant. For them, obviously, the A1C goal is below 6%. And there are some exceptions, like I said, to this A1C goal. Factors to consider, which is age. Let's say like elderly patients, like over 70 years, we don't want them to be like 6.5 or closer to 6%. It's okay to be around 7 or 7 to 8%, or it also depends on what's the duration of diabetes, hypoglycemic awareness. If they have any risk factors, that is cardiovascular disease or chronic kidney disease, yes, we aim at the tighter glucose control, but again, not at the risk of having hypoglycemia. And this is when they're using the CGM, we want to keep them sugars in the target range, which is between 70 to 180 over 7. Our goal is to keep them over 70%, and high should be, that is over 180, should be below 25%, and the low should be below 4%. That's our goal. And that takes us to the average A1C, average blood glucose around like 175. Next, MODY or maturity onset diabetes of the young. So this should be considered if exceptional cases. That means the diabetes presents within first 6 months of life. But again, it can also present later, like in 20s and 30s or even 40s. But it's a diabetes without typical features of type 1 and type 2. That means they have C-peptide normal, antibodies are negative, there is no obesity, they don't have metabolic syndrome features, and they have a strong family history of diabetes on one side of the family. That means, let's say, like their parent and let's say like mom's sisters or mom's brothers, and then mom's parents and their grandparents. So like successive 3 generations on one side of the family has family history of diabetes. Most of them are probably diagnosed as type 2 diabetes. And they have stable, mild fasting hyperglycemia, usually like 100 to 150, stable A1C between like 5.6 to 7.6, and definitely there is no obesity. So their body habitus does not fit to type 1 or type 2 diabetes. Treatment, depending on, there are like total 13 genes involved in it, and there are 7 different MODIs, and different MODIs have different treatments. Some are just like monitoring, some has diet modification, some benefit with sulfonylurea, and some benefit with the insulin. Gestational diabetes diagnosed during pregnancy. Usually we screen for gestational diabetes at like 24, usually at 28 weeks. That's the beginning of the 3rd trimester. In pregnant patients not previously found to have diabetes or high-risk abnormal glucose metabolism early in the pregnancy. And we have like screening, either one-step strategy or the 2-step strategy. One step is the 75 gram or the 2-hour OGTT, which I think the OBGs don't do this. They usually start with the 1-hour OGTT, and if they fail it, then they go to the 3-hour OGTT, and these are the blood sugar goals. If they fail this, then yes, they have gestational diabetes, and they refer to the diabetes educator, and if needed, endocrinology, and we start checking blood sugars fasting and either 1 hour or 2-hour postprandial. Their fasting blood sugar should be below 95 during pregnancy. 1 hour postprandial should be below 140. 2-hour postprandial should be below 120. If their sugars are running above these goals, then we consider adding them on insulin. Just the insulin. We don't use any other pills or anything else during pregnancy. Per the recent guidelines, we just use insulin, basal, with or without prandial insulin. And recently, FDA approved CGMs during pregnancy. So if they have gestational diabetes, we can get approval for the CGM. Libre 2, Libre 3, and the G7 are the approved, or the current CGMs approved for pregnancy. And when patients have gestational diabetes, they're at risk for developing prediabetes or type 2 diabetes in the future. So we screen them for prediabetes. Per guidelines, we have to do the 2-hour OGTT, but I just do A1C 3 months after delivery. And this is when they're using CGM during pregnancy, and look at this target range. It's not 70 to 180 like non-pregnant patients. During pregnancy, our goal is to keep them mostly between 63 to 150, and we call it as hypoglycemia during pregnancy if it's below 63. So 63 to 70 is still normal blood sugar during pregnancy. And we want them to be in target range at least over 70%. Above target should be less than 25%. Below target should be less than 5% in total. And now Kimberly is going to talk about the diabetes technology.
Thank you, Dr. Gorantla. All right, so when it comes to technology for monitoring your blood sugars, you got a couple of options. You can do finger stick blood glucose monitors or continuous glucose monitors. There's a couple of things that you really want to consider. First, accuracy. Meters can be very reliable, but they will vary by the brand that you get. And two, when you're looking at your readings, like on a sensor, if it's a very high reading or a very low reading, it may not be as accurate. Is your patient on an oral agent or are they on basal insulin only? That can determine whether or not you can qualify for a CGM or not. Can the patient use the technology? Does it make sense to get them on something that's way over their head and they aren't going to be able to use safely? Also, do they have a smart device that is capable of integrating with it? So if they are thinking about a pump, do you want to put them on a Libre 2 if it's not going to integrate with the pump that they are going to be going to? So you want to keep that in mind too when you start them on a technology device. Calibration. Some patients don't mind calibrating. If you're going Medtronic route, you're going to be doing calibrations. If you're going a tandem Dexcom, you won't be doing calibrations. So some other things. And then the final determining factor, cost. This is just a picture of a lot of different options. Let's see if I get this right. Oh. Is this one? Yep, right there. All right, up top in the corner here, this is a Eversense. This is a little capsule that gets put underneath the skin, and then you wear this transmitter on the outside, and it sends the data. Right down here, this is your Medtronic Guardian sensor. This works only with Medtronic devices. Here in the middle, this is your Freestyle. Right here is a Libre 2. This is a Libre 3. This is the smallest device that's out there right now. Over here on the far end, this is your Dexcom. You see a G6 here. I don't have a picture of a G7. And then down here in the corner, your finger stick glucose glucometers. All right, blood glucose monitors, there are multiple brands, as I said, and sometimes your insurance is going to dictate which meter you need to get and fill. There are intermittently scanned CGMs, so this would be like your Libre 14-day and a Libre 2. There's also now a Libre 2 Plus, which can integrate with some of the technology or some of the pumps. Real-time CGMs, so your Dexcom G6, G7, Eversense, Libre 3, and Guardians. They will give you continuous readings. And then there's also a professional CGM. Keep this in mind if you have somebody who maybe isn't interested in wearing a sensor, but you really want to get some information out of what they're doing at home. They can come in, they can see one of the diabetes educators here at MGMC, and they can put it on, have them come back in a couple of weeks, take it off, and get the data, can look at it, say, they're going high after certain meals or they're going low or overnight, and make some suggestions for change. It's 2 weeks. It can be covered by their insurance, and then they don't have to look at it again. It can also be blinded or unblinded, so the patient could get that data right away, or they don't have to think about it at all. Libre Pro also has one too. Yep. This website here, this is by the ADA. It takes you right here. I just have the top of the screen, but there's all kinds of different technology products out there. And so if you went here, you can compare them and see which one might be something that you want to look at. We are going to be just focusing on the sensors since that is where I think the technology really is right now. Intermittently scanned CGMs, Freestyle Libre 14. It has a reader. There is no calibration required. It does have a 1-hour warm-up, and it lasts for 14 days. 14 days is kind of nice. You only need to change it once every 2 weeks. And then, as I said, you scan it with either the phone or reader that you see right there. Also, the Libre 2, also no calibration. It does have a 1-hour warm-up to 14-day duration. This one is a little bit more advanced. It does give you alerts for a low or a high reading. So it would go off and you need to scan it then to see what your reading is. I did put on the bottom here, Libre 2 Plus. It is a newer option, and it is compatible with some of the insulin pumps out there, like Omnipod 5 and your Tandem T-Slims. Real-time CGM. So these are ones that are going to give you constant readings. Libre 3, staying in that freestyle family. This is not needing any calibration. It also has a 1-hour warm-up. Again, 14-day duration. It is the smallest CGM out there. It is teensy tiny. And it will give you readings every 1 minute, so you're getting data all the time. Dexcom family, G6, also does not require calibrations. It is a little longer warm-up, 2 hours approximately. It doesn't last quite as long, 10 days, and it will give you readings either by a receiver or a smartphone every 5 minutes. It is also compatible with some of the insulin pumps out there. Got them listed right there. And then transmitter is separate. So on this, oops, I did it again. On this one, your sensor right here is that transmitter. And that needs to be reused for 3 months. So if you actually are in the hospital like I am, and somebody comes in with one of these and you take it off, don't throw that away. That needs to be reapplied with their next sensor when you put it on. Dexcom G7, again, no calibration. This one's a little quicker to warm up. It only takes about 30 minutes. This one also 10 days duration, but it has a little bit of a grace period of about 12 hours. So if it's expired, it will continue to read and it's not going to just shut off. Readings are about every 5 minutes and is also compatible with some of the insulin pumps out there, and those are listed down below. You'll also see iLet. This is the only sensor that is compatible with the iLet pump that's out there now. Medtronic pumps, Guardian 3 and 4. These do require calibration, and although it says not with the Guardian 4, if I understand how it works correctly, if you do put in a glucose reading from a meter, it will calibrate it for you. So it takes a little bit longer, again, 2-hour warm-up, and it is a shorter duration. You have to change this every 7 days. Readings every 5 minutes, and it's compatible with your Medtronic pumps. Eversense, this is one I was talking about. That's that little capsule that's put in. This, you do have to calibrate every 12 hours. So even though you have the sensor on, you're still doing your finger sticks to keep this running. There is no warm-up, so once it's in, it's good to go. Here's the nice thing, though. It is 6-month duration, so you don't have to change it every week, every 10 days, every 14 days. It's in. This transmitter, oops, there we go again. This transmitter right here, if this comes off, you just reapply it. You don't have to stick it into the skin. It's just on top of the skin. And this can be done outpatient, clinic, so you can bill for placement and removal. Coverage criteria. Keep in mind, this is gray, not black and white. Medicare, Medicaid for Iowa at this point, if your patient is taking insulin at least once a day, and they either have hypoglycemia documented, hypoglycemia unawareness, or they have poor control, so like A1C over 7%, they should be covered for this. And I say should because you can still get pushback from this, unfortunately. If they are going Medicare, Medicaid for some coverage submission, you want to send this to your DME suppliers. Commercial insurance, I can't tell you what you're going to have required. They're probably going to need a prior authorization, and they may say insulin injection once a day. They may say multiple daily injections. You're just going to need to find out what your insurance is going to require for coverage. And then these prescriptions will typically get sent to your pharmacy. Going back again, you want to offer CGMs to as many people as you can, simply because it gives you so much data. So any adult who is on insulin therapy, anyone on type 1 or type 2 with type 1 or type 2 diabetes who is on multiple daily injections or on an insulin pump, as Dr. Gorantla had said, pregnant individuals with would really benefit from a CGM, so get them started on them. And again, I said, if you have somebody who doesn't really want to do a CGM, but you want to get that data, it might not even be a bad idea to put one on for 2 weeks, get that information, and then maybe adjust their insulin plan. And then when you see them back in 3 months, see how they're doing, put it on again. It is a possibility for them. Some over-the-counter options. So there are some new things coming out this summer. In fact, August, the first one here, Dexcom Stelo, is supposed to be hitting the market. It is being marketed for individuals with prediabetes or diabetes type 2 who is not on insulin, so your oral agents only. So if they may not qualify with their insurance for a different CGM, this might be an option for them. There is an associated app so that you can get your data. There are no alarms with this one, unlike the others, and sampling is a little less frequent. So unlike the every minute or every 5 minutes, you're getting your readings about every 15 minutes. But every 15 minutes is a huge improvement from, say, a glucose once, twice, 3 or 4 times a day. The other two options coming out are Freestyle products. Freestyle Rio is being marketed for those individuals also with prediabetes or type 2 diabetes. Again, no insulin requirements here, and also decreased sampling, so not the every minute sampling that you would see with the Freestyle products. Freestyle Lingo is more towards those individuals who are looking for some behavior changes. So want to get healthier. I want to see how my glucose is responding to my lack of sleep or what I ate or the activity that I did. So that is how the Lingo is being marketed at this point. It has an associated app. It has health behavior coach in there. There also is no alarms and the decreased sampling frequency. Price points on these, I do not have at this point, but I will tell you, because they are over the counter, they are supposed to be lower. If you look at your insurance coverage, you could be looking anywhere from $0 to $400, depending upon out of pocket, what you've got for coverage. A lot of the Libre, if you use their coupon, you can get it for $75. So anticipating when these are coming out, they're going to be on the lower end of the price point. And that said, what questions can we answer?
Go ahead, Dr. Kitchell.
Can you hear me okay?
Yes.
The continual glucose monitors, who actually reads those? Do the patients read them and do they act on it themselves, or do they have to have a nurse practitioner who's a diabetic specialist or a primary care doctor, or do the endocrinologists have to review these?
So Dr. Kitchell was asking, with the continuous glucose monitors, who is actually reading those numbers? So the numbers themselves, the patients can read. If it were a pro, you could have it blinded or unblinded. So if you blind it, obviously the patient's not getting any of the data. But otherwise, on all of the other ones, they will be able to get that data either on a reader or on their phone app. When they come in to see a diabetes educator or the endocrinologist, that data can be uploaded, so you get an entire report then, and you can see like a couple weeks at a time of all their glucose readings, their frequency of lows, their frequency of highs, how much they're in target range. So a little bit of both, I guess, if that answers your question.
So it looks as though you'd want this, though, for their visit to either the diabetic educator or the nurse practitioner or the endocrinologist. Does the primary care doctor do much with this, or is it usually a diabetic specialist?
Well, how much your primary care provider knows. Most of these patients too should be able to access this information. A lot of patients will come in with like a Clarity where they can just pull it up for your provider. If you ask them, can I see your account? And you can get a lot of that information right on your Clarity on your phone. So they could even look at it without having to download it themselves.
Most of the primary cares, they don't know. Most of the primary cares, they don't know how to download them, because they have to go to the Gluco website, or there are some websites that the diabetes educator office or our office, even I don't know, to be frank. So the nurses do that all for us. So the nurses at the primary care, they probably are not trained. So they probably won't be able to download. But some smart patients, they just download the data like last 2 weeks and they take them to the visit. Then the primary cares can interpret and change the medications depending on the trends.
It may be too early to judge, but assuming somebody has the right medication and glucose monitoring and it's all done perfectly well, what's the difference between the prognosis for kidney disease, congestive heart failure, or cardiac disease for 10 or 20 years from the time they have begun the continual glucose monitoring. I presume they have a much better outcome long term.
Yeah, I don't know if they have done the studies in the long term, but definitely if they are like adequately well controlled, like at the goal with A1C like below 7%, they shouldn't be having like much increased risk of cardiac. Like it should be matching the normal men or women of their age. So when they're well controlled, so based on the CGM, like most of the patients use CGM so that they are well controlled or no. So if they're well controlled within the ranges where they should be, then their risk is same as their age comparables.
And sorry, I have so many questions, but you mentioned the cost of some of these medications. And what percentage of Medicare, Medicaid, or commercial insurance actually have coverage for the medicines and then also for the CGM?
So most of the private insurances usually cover the expensive, the GLP-1s or the dual receptor blockers or the SGLT2s or DPP-4. These are the expensive classes. If they have private insurance, yes, most of them are covered. They have a copay of like $25, but as long as they don't have the high deductibles. Some patients have high deductibles for the medication, then they don't work. Some patients, they can download the coupons, but again, they work as long as they don't have the high deductibles. If they have high deductible, no matter the coupons doesn't work or nothing works. For Medicare, Medicaid, they cover partly. It depends on their plan. Like if they have the Part D, the drug plan, yes, they're better covered, but they still have copay anywhere from $50 to like $150 or $200. Some patients even pay like until they reach the donut hole, they pay like a little bit less. Once they're in the donut hole, they have to pay like a lot of money. So it depends probably on their insurance plan. And for the CGMs, again, if they have Blue Cross Blue Shield, Freestyle is now, it's only $30, regardless of whether they're on insulin, they're on the pills or anything. And one advantage with Freestyle is even if they don't have any insurance, they can just pay out of pocket, which is only $75. So that's one good thing. Like when patients, they really want to know, but their insurance is not covered, because Dexcom is sometimes like it's like $200 or $300 per month if it's not covered by the insurance. In that way, Freestyle is cheaper. You just pay $75. Again, this is what the rep told me. If they pay over $75, they can call the Abbott company and they get the money refunded back. So Freestyle is relatively cheaper than the Dexcom if they don't have insurance or if it's not covered by the insurance.
And what would you say, though, is the percentage of patients for whatever carrier they have? What percentage actually get the ideal medication and CGMs? What percent do get it? What percent don't get it?
It depends on the medications. The expensive medications, yes. Like I have like 50-50. Like when they're like on Medicare or sometimes Medicare, Medicaid, I mostly start with metformin, glipizide, and then go to the insulin. Those are the cheaper options. But when they have private insurance, depending on the risk factors, I try to do those expensive medications because they have more advantages than the regular novel use cheaper medications.
It just seems to me, though, that if Medicare and Medicaid really thought long term, they probably should give all the best medication away.
At least they made insulin cheaper. In that way, like a lot of people are happy with that $35 mark for the insulin, because it was even more expensive before. Even for the private insurance patients, now type 1s, a lot of times they complain that insulin is very expensive.
And that's something else to consider too. Some of these patients, with this change with the insulin cost, they were on probably some less than ideal insulins because they were less expensive. Well, now that it is now $35, don't be afraid to switch it up. You know, if you're looking at it and they're on a 70-30 because I can afford it, well, is that ideal? Are they having hypoglycemia? What are they doing after their meals? Do we really need to just get you on a different plan altogether now?
And how many diabetic educators are there at Mary Greeley? I know McFarland Clinic used to have diabetic educators, but we don't.
We don't have anymore, yeah.
Yeah. Hold on, 1, 2, 3. 6, 7. 7 diabetes educators, and then there are 1, 2, 3 inpatient dietitians.
Are they all diabetes educators? I thought some of them are dietitians.
Yeah, I was to say, and of those diabetes educators, 1, 2, 3, 4 are also dietitians. So the others are nurse diabetes educators. So there's a fair share up there. They do a great job, a very good job.
Yep.
Other questions?
One more question. We used to have quality measures, and those quality measures included how many diabetic patients were admitted to the hospital during a particular year. I don't know that Medicare does that measure any longer, but we still have measures for the hemoglobin A1C control, and we do very well nationally with the lower, we're in the lowest 10 percentile. In other words, we've got the best control of our diabetic patients according to Medicare.
Yeah, as long as they show up, yes, we do A1C every 91 days. If they don't show up, obviously, yeah, they don't have them.
And I was going to tell you too, with the MGMC, the outpatient diabetes education department, they have goals that they have to set in order to be credentialed as a center there. So they do set those goals, and they have new ones that they set every year. All right.
Good, thank you.